Chapter 13, treatment of gout, osteoarthritis, and rheumatoid arthritis. Gout is also called gouty arthritis. It's a disease that is associated with hyperuricemia. Hyperuricemia is a condition in which urate levels build up in the blood serum, and urates are the product of the metabolism of purines. Prevalence of gout is actually more greater in men than women until menopause, and then it kind of equalizes. If you've never known anyone with gout, or even if you don't know what gout is, it usually causes pain in the ankle foot area. It can get so bad to where they need to walk with a cane, or they're in so much pain they can't walk at all. And then, of course, there's like less severe attacks. So if we give a patient medication to help stop attacks and help make the attacks more bearable, this is something that won't happen as frequently. So it's likely that the relationship between hypertension and hyperuricemia is caused by decreased renal clearance, resulting in accumulation of urate. Hyperuricemia is a risk factor for diabetes and associated with increased insulin resistance. Obesity severely increases your risk. Weight loss reduces hyperuricemia and insulin resistance. Hyperuricemia can cause kidney disease, and it can make kidney disease even worse. Gout is characterized by buildup of urate crystals in joints. There they produce inflammation and pain. Deposits of uric acid are called tophi, which is singular, and then tophus, which is plural, and look like lumps under the skin around the joints and at the rim of the ear. So figure 13.1 shows gouty arthritis, so it can happen in other places. I've mostly known people to get it in the foot area, but those hands right there are definitely gouty arthritis. The joints most commonly affected are the big toe, foot, ankle, knee, wrist, finger, and elbow. Consumptions of food or beverages high in dietary purines can produce a flare-up of gout symptoms. So for example, beer consumption increases the risk of a gout attack because beer has high levels of purine. Box 13.1 is going to name off some purine contents of food. So foods considered high in purine content: alcohol beverages, like we said, fish, seafood, shellfish, anchovies, sardines, herring, mussels, codfish, scallops, trout, and haddock. Meats such as bacon, turkey, veal, and venison, and organ meats such as liver and sweetbreads. Foods considered moderate in purine content are meats such as beef, chicken, duck, pork, and ham, crab, lobsters, oysters, and shrimp. Vegetables and beans such as asparagus, cauliflower, kidney beans, lentils, lima beans, peas, mushrooms, and spinach. Grains like oatmeal, whole wheat bread, and cereal. And then foods low in purine content are going to be dairy products, eggs, fruits and vegetables, and grains. Some people with gout will experience sharp needle-like painful symptoms, but some people will have no symptoms at all. Acute gout attacks usually resolve spontaneously in 7 to 10 days without treatment. However, people with symptoms may benefit from treatment. Drugs prescribed for the treatment of gout include anti-inflammatories, uricosurics, and inhibitors of uric acid synthesis. Colchicine is one of the oldest agents used to treat gout. It can be used to treat or prevent symptoms. It penetrates inflammatory cells and inhibits their ability to respond to irritation. So it can be taken for acute gout, like I'm having gout pain right now, I need to treat it. It can be used for that, and it can be used to prevent those attacks. A uricosuric is a drug that increases the renal clearance of urates. Urate lowering drugs are indicated for patients who experience frequent attacks of gout, more than 2 to 3 attacks per year, in order to prevent further gout attacks. Probenecid is a uricosuric that inhibits the reabsorption of uric acid in the renal tubules and therefore promotes the elimination of urates. So there is a combination medication with probenecid and colchicine in there together. Just a side note, thiazide diuretics like hydrochlorothiazide and low dose aspirin are also known to increase urate levels. Xanthine oxidase inhibitors block the final enzymatic step in the synthesis of uric acid. Allopurinol and febuxostat are xanthine oxidase inhibitors. Allopurinol is readily absorbed when administered orally and is easily eliminated in urine. Febuxostat, which is Uloric, is more selective than allopurinol. Gout flare-ups have been reported when febuxostat therapy is initiated. So here's just the dosage forms and strengths. The Uloric, the febuxostat is only available as a tablet, where allopurinol, we have an injection powder for reconstitution. Recombinant urate oxidase enzymes lower uric acid levels by metabolizing uric acid to the water-soluble benign purine metabolite allantoin, which is excreted in the urine. Pegloticase is U.S. Food and Drug Administration approved for patients with chronic gout. Rasburcase is indicated for the treatment of hyperuricemia in patients who are receiving chemotherapy that have elevated uric acid, and these are administered intravenously. So there's no other option besides intravenous. Now we have the usual dosages and warnings for drugs used in the treatment of gout. For colchicine, we should avoid alcohol, which should be done anyways when someone has gout or is having a gout attack. Should be taken with a lot of water. Same with probenecid. We should avoid aspirin, which we just read about how aspirin can increase urate levels. Should be taken with food. Allopurinol should be taken with food. Avoid alcohol. This one can cause dizziness or drowsiness, and it should be taken with 10 to 12 glasses of water per day. The warnings for pegloticase and rasburcase are a little bit different since the patient is not going to be administering it themselves. So when we mix it, we gently need to invert the IV bag and not shake it. We need to refrigerate the diluted solution and use within 4 hours of reconstitution, and that's for the pegloticase. Arthritis is a condition that produces joint pain. Inflammation of the fluid that surrounds the joint, synovial fluid, contributes to the pain associated with osteoarthritis. Osteoarthritis is the most common of all arthritic conditions. It is the leading cause of musculoskeletal pain. Acetaminophen, aspirin, and NSAIDs are used to control pain. The primary anti-inflammatories used for treatment of acute gout and osteoarthritis are NSAIDs and corticosteroids. The most commonly prescribed NSAID for gout is indomethacin. However, ibuprofen, ketoprofen, and naproxen are also administered. The COX-2 inhibitor, celecoxib, may be prescribed for the treatment of acute gout. Celecoxib remains the only COX-2 inhibitor available for sale in the United States. So just a little FYI, when medications are the only one in their class, they tend to be good examples of questions you might see on the PTCB exam. As per FDA requirements, manufacturers of all NSAIDs must print a box warning in the package insert describing the risk for cardiovascular toxicity and GI ulceration. We have a table here with non-steroidal anti-inflammatory drugs, NSAIDs. Just talked about all of these. Naproxen is available as a leave, and the prescription strength is either EC naproxen or naproxen, and then there's naproxen sodium, which the pharmacy only strength is Anaprox and Anaprox DS. Rheumatoid arthritis is an autoimmune disease that is characterized by inflammation of the lining of the joints. An autoimmune disease occurs when immune system turns against the parts of the body it is designed to protect. The body attacks its own cells, thinking they are germs or a harmful foreign substance. No one knows exactly why autoimmunity develops. It is believed that several factors may be involved. The trigger may be an exposure to a virus, environmental toxins, the sun, genetics, hormonal changes, drugs, pregnancy, any combination of those things. And what is known is that autoimmunity can affect any organ of your body. In addition to chronic inflammation, RA produces pain, joint damage, and disability. Most people who have RA have high levels of rheumatoid factor, an immunoglobulin, which is an antibody that regulates other antibodies made by the body. RF is not specific to RA, so it's present as part of the diagnosis for RA, but it is not a definitive diagnostic tool. There's 3 distinct phases of the disease. In phase 1, the joint lining, the synovium or synovial membrane, becomes inflamed, causing swelling, pain, and stiffness. In phase 2, rapid cell growth causes the synovium to thicken. In phase 3, inflamed cells in the synovium release enzymes that digest bone and cartilage. The result is more pain and disability. The damaging chronic cycle of inflammation is stimulated by pro-inflammatory cytokines, such as interleukins and tumor necrosis factor. RA and other autoimmune diseases that affect the musculoskeletal system are treated using pharmacologic and non-pharmacologic therapies. Drug therapy is aimed at suppressing inflammation, pain, and immune system response. Drugs that are used to suppress inflammation and reduce joint swelling and pain include glucocorticosteroids like dexamethasone and prednisone, NSAIDs like celecoxib and naproxen, and salicylates like aspirin. Disease-modifying anti-rheumatic drugs, so DMARDs, are an important group of drugs that slow the progression of RA. Azathioprine and methotrexate, they're immunosuppressive drugs. Hydroxychloroquine, an anti-malarial, which I'm sure we all heard about during the whole COVID thing. Sulfasalazine and Fluunamide are examples of DMARD. Another class of DMARDs are called biologic response modifiers. These include TNF inhibitors like adalimumab, which is Humira, certolizumab, etanercept, and golimumab. Then we have IL antagonists. So that includes the anti-malarial hydroxychloroquine and gold salts. Glucocorticosteroids are prescribed to suppress inflammation, reduce flare-ups, and treat pain associated with RA. Oral prednisone and intra-articular injections of corticosteroids may sometimes be given when only one or two joints are involved. Glucocorticosteroids have immunosuppressive actions, and they inhibit the synthesis of antibodies that are responsible for attacking the body's health cells. They decrease the accumulation of cells that mobilize to fight when the body believes it is under attack, such as leukocytes and T cells. They interfere with the binding of antibodies to receptor sites of the cell surface. Glucocorticosteroids are potent anti-inflammatory drugs as well. They decrease the synthesis of pro-inflammatory substances such as prostaglandin, leukotriene, cytokines, macrophages, and they're released as part of the inflammatory response, and they cause swelling, pain, irritation, and other effects. Glucocorticosteroids may also be prescribed for the treatment of ulcerative colitis, allergic reactions, cerebral edema, and septic shock. Short-term use of glucocorticosteroids can cause nausea and weight gain, can produce edema and hypertension, and they can produce hyperglycemia, leading to diabetes. Other adverse drug effects could be osteoporosis, poor wound healing, increased risks of infection, and the GI tract has ulcerations. Glucocorticosteroids may initially produce muscle weakness. This is a serious problem for people with myasthenia gravis, given that muscle weakness is a symptom of the disease. Long-term use of glucocorticosteroids may increase the need for potassium, vitamins A, B6, C, and D, folate, calcium, zinc, and phosphorus supplementation. In this chart, we have glucocorticoids used in the treatment of rheumatoid arthritis. Dexamethasone comes in an elixir, an oral concentrate, an injection solution, and tablet in many strengths. Hydrocortisone is available as a tablet, so this is not the cream. This is a tablet and an injection. Methylprednisolone, we have a suspension for injection and a powder for injection, and there's tablets. And you might have taken this before. It comes in a little dose pack. One of the forms comes in a dose pack and tells you what to take every day. Prednisone, we have oral solutions and delayed release tablets and tablets. So we kind of already talked about DMARDs, but immunosuppressive drugs interfere with the formation of immune cells by damaging RNA and DNA needed for cell replication. They may also block immune system response to autoantibodies. An autoantibody is an abnormal antibody that attacks healthy cells and tissues. Azathioprine, cyclophosphamide, cyclosporine, and methotrexate are immunosuppressive drugs used to treat RA. Methotrexate was one of the first drugs used for the treatment of RA, and it continues to be used as a monotherapy or used along with other DMARDs. In addition to RA, methotrexate is prescribed for many other things: treatment of leukemias, neoplasm, psoriasis, breast, lung, head, and neck cancer, the GI tract, testes cancers, and osteosarcoma. Immunosuppressives used in the treatment of rheumatoid arthritis, which we've already talked about, but here are the dosage forms and strengths. So for cyclosporine, you can see there's many different, we have capsule solutions, injections, methotrexate, tons of stuff because this is such a widely used drug. So many different brand names, Rheumatrex, Trexel, PFS, tons of different things. So it's available as a powder for reconstitution, an injection solution, an oral solution, a subcutaneous injection, a pre-filled syringe. So many different forms, as methotrexate, like I said, is very popular. Antimalarials have anti-inflammatory and analgesic properties that are useful in the management of RA. Although the exact mechanism of action is unknown, antimalarials are known to accumulate inside cell structures where they raise the pH and interfere with processes that are normally stimulated when the body thinks its own cells are harmful antigens. An antigen is a substance that stimulates an immune system response. The most common adverse reaction for antimalarials is GI irritation. However, hydroxychloroquine can cause permanent damage to the retina, resulting in blindness. That is mostly associated with people who have been taking it for greater than 5 years at pretty high doses. So Plaquenil, it only comes in a tablet and it only comes in 200 milligrams. Fluunamide is a DMARD that is approved for the treatment of RA, and it selectively blocks the replication of lymphocytes by interfering with pyrimidine synthesis. Sulfasalazine was developed by combining an anti-infective agent with an aspirin-like anti-inflammatory agent. It slows the progression of RA and takes approximately about 2 to 3 months for the effects to be at the maximum level. Gold compounds are also used in the treatment of RA. However, because of side effects, cost, and lack of sustained effectiveness, use of these is limited now. But they are believed to affect the function of B cells and macrophages, which are part of the immune system response. They decrease the release of antibodies and cytokines and inhibit the action of collagenase. Gold compounds may be delivered by mouth or intramuscular injection. The onset of action is slow, and it can take 4 to 6 months before maximum effectiveness is achieved. Gold compounds can produce temporary remission in approximately 50% of the people who respond favorably to the drug. So we have miscellaneous disease modifying anti-rheumatic drugs, their dosage forms and strengths. Many DMARDs are biologic response modifiers. They interfere with the inflammatory process by reducing mediators of the inflammatory response. They inhibit the release of cells that mobilize to fight when the body believes a harmful invasion is happening. They inhibit the release of substances that produce inflammation. Chronic inflammation can cause a degeneration of nerves, bones, and muscles. Biologic response modifiers interfere with the activity of immune system mediators such as cytokines, leukocytes, B cells, and T cells. TNF is a cytokine that is released by specialized cells to fight what the body believes is a harmful invasion. High levels of TNF are found in the synovial fluid of people with RA, and the factor is responsible for joint damaging inflammation. TNF alpha inhibitors are genetically engineered drugs that block the inflammatory process triggered by high concentrations of TNF. They prevent cell lysis, which is destruction of the cell, and release of the substances that cause inflammation. Adalimumab, which is Humira, certolizumab, golimumab, and infliximab are monoclonal antibodies that bind to TNF alpha receptors to reduce mediators of the inflammatory response. Etanercept is a fusion protein that inhibits TNF alpha. Just a side note, cytotoxic waste. So medications like cyclophosphamide, methotrexate, and azathioprine, including bags, sets, tubings, drug vials, gloves that you use for any of those things must be properly disposed of in the cytotoxic waste containers. Monoclonal antibodies do increase the risk for opportunistic infections. The most commonly reported opportunistic infections are tuberculosis and fungal infections. MAB is the common ending for monoclonal antibody drugs. Then we have this table with biologic response modifiers used in the treatment of rheumatoid arthritis. In the US, we have Orencia, which is just available as an injection. And I think, yep, most of these, all of these actually are only available in injection form. All right, now we have our chart with dosages and warnings for drugs used in the treatment of rheumatoid arthritis. For the first set, we already talked about those. We talked about those in the beginning. Hydroxychloroquine, we should avoid antacids within 2 hours of dose. It should be taken with food and avoid prolonged exposure to sunlight. So what that means is if a patient taking this medication decides to go to the beach, they're more than likely going to get way more sunburn than they would normally. Immunosuppressives, all of them should not be used in pregnant women. Alcohol should be avoided with all of, well, azathioprine doesn't list alcohol as something to avoid, but I don't know, I would. For methotrexate, the patient should avoid aspirins and NSAIDs. And for cyclosporine, the patient should avoid grapefruit juice. For biologic response modifiers, most of them are protect from light and refrigerate, do not freeze. Cimzia, the certolizumab, should be site of injection should be rotated every time. And most of those are going to be that way. An interesting side effect and warning for DMARDs. They may discolor the urine or skin to an orange yellow substance. And when you work in the pharmacy and you actually see the bottle of sulfasalazine, you will see maybe why. It's very, very powdery and very, very yellow.